Hi everyone, this is Tim, your Block 3 lecture instructor, and this PowerPoint voiceover is going to be on cancer. Specifically, it's going to be on gastrointestinal cancer, hepatic cancer, pancreatic cancer, renal, and testicular cancer. And the last couple slides are going to be more of the patient who is receiving chemo and how to care for them and signs and symptoms and interventions. So this is a little lengthy, and it's because there are so many cancers. I'll try to keep it as brief as I possibly can. There are going to be some statistics and some data and stuff. I don't really necessarily want you to memorize those numbers, but just be more aware of how your patient got the disease process. Whether it was diet or living conditions or hereditary, things like that. Just be more aware of how they got it, what we're doing as far as assessing and treating, and whether or not they're able to either live with it. They will ultimately die from it, or whether or not they're able to actually get rid of it. So keep those things in mind. So the first cancer is going to be gastrointestinal cancer. This is a malignant growth of the mucosal cells in the inner lining of the stomach. Can move from the muscle and metastasize to other areas of the body. Causes are believed to be H. pylori infection, a diet with smoked, highly salted, processed, or spicy foods. Smoking and drinking also contribute to this, and ultimately gastric ulcers. My opinion is that the gastric ulcers are probably caused by those other things. Your body is trying to heal those ulcers as best as it possibly can based on homeostasis, and it didn't quite work the way it's supposed to, and we end up having some sort of tumor or malignant cancer. Complications include hemorrhaging, obstruction, metastasis, and dumping syndrome. And the goal ultimately is to actually remove the tumor or the infected tissue and provide some sort of nutritional program. So if they are able to get over this, then they're not actually starting another problem. Again, I think that those who are 45, 50, 55, 60 years old and they're between the gastric ulcers or some sort of poor choices in food, as far as, especially, I mean, we're Americans, we eat a lot of processed foods and things that have a lot of salt in them. Not necessarily means we're going to get cancer, but I think that, when you're old enough and you've lived a long life of the same foods and the same types of foods, it's hard to really be able to change that. And so the nutritional program is definitely going to benefit your patient, but I think it might be a little harder for them to adjust and to, make changes in their diet based on the gastrointestinal cancer. Here's a picture that I had downloaded off the internet. It really just kind of shows you what the different types of cancers are and how they actually affect the patient. For assessment, early symptoms are going to be indigestion, abdominal discomfort, the feeling of being full, epigastric, back pain, or retrosternal pain. Late symptoms are going to be weakness and fatigue, anorexia and weight loss, nausea and vomiting, sensation of pressure in the stomach, dysphagia and obstructive symptoms, and ultimately iron deficiency anemia. I think this kind of makes sense, and I don't mean to dumb this down, but I think that if you really look at or think about it as being, early symptoms. I've got the indigestion, I've got the feeling of being full, I'm having, stomach pains. That leads to nausea and vomiting and just not feeling well and not wanting to eat. The lack of food is going to cause your weakness and your fatigue, and it's going to cause weight loss and anorexia. The dysphagia and obstructive symptoms are going to come much later, but essentially if you're not really consuming enough food that has enough nutrients in it, you're going to be iron deficient. So and especially with the anemia, you're not producing enough red blood cells, so essentially that's going to lead to more weakness and fatigue and just not feeling well. So it's a cycle, but it really just starts with the fact that you just weren't eating well enough, and then prolonged period of time it just makes you sicker. Interventions are going to be monitor for vital signs. You're going to monitor for H&H. If you're severely anemic, then you're probably going to have to transfuse a unit or two of packed red blood cells. You're going to monitor their weight based on the fact they're not consuming food. They're going to lose a lot of weight and probably atrophy. Assess nutritional status. Encourage small, bland, easily digestible meals with vitamin, minerals, and supplements. And this kind of makes perfect sense. The more, your patients aren't going to have or want to eat normal meals, breakfast, lunch, and dinner. So try to get them to eat as many small, frequent meals as they possibly can, packed with vitamins and minerals and proteins and things that they'll actually be able to easily digest, but give them the biggest bang for their buck, if you want to call it that. You're also going to administer pain medication based on the fact that it's going to be having the abdominal or the gastric pain, and it may need chemo or radiation therapy. Essentially, you're either going to remove it by surgically removing it, you're going to try chemo or radiation therapy. It's something that I give as far as being able to get that out of there. So. As far as surgical interventions, they're going to do a Bill Roth 1. They can also do a Bill Roth 2, and then a total gastrectomy, which is removing the stomach altogether. You have to remember, this is where your food is digested and broken down and shifted to the small intestines for the absorption and stuff. So when you kind of remove these things, you're changing the anatomy of the body itself, and it's hard for it to just change. Intestinal tumors and colorectal cancer. These are malignant lesions developed in the cells lining the bowel wall or developed as adenomastose polyps in the colon or the rectum. Tumors are spread by direct invasion or through the lymphatic or circulatory system. Your bowels are highly vascular, and it stands to reason that the tumors are spread by the lymphatic or the circulatory system. It's easily for, excuse me, for the circulatory and lymphatic system to pick stuff up and actually drop stuff off. So I can see it spreading very easily. Complications include bowel perforation and peritonitis, abscess and fistula formation, hemorrhaging, or complete intestinal obstruction. The complete intestinal obstruction is probably more as far as whether the tumor is on the inside of the intestines or on the outside. It's actually grown so large that it's actually pushing on everything, and it's pinching things off. So other risk factors are age older than 50 years, familial and family history of colorectal cancer, previous colorectal polyps or cancerous polyps, history of chronic inflammatory bowel disease such as Crohn's and diverticulitis, and we've got colitis, or history of ovarian or breast cancer. The picture they post on here's the picture of the polyps. The best way to determine whether or not it's actually cancer is to really go and do a colonoscopy, look for the polyps, actually snip them off, and send them to a pathophysiologist, and that way they're able to do some studies on them, determine if it's actually cancer or not. Assessment for this is going to be blood in your stool, anorexia or vomiting, and weight loss. It's also be anemia because you're obviously not feeling well enough to eat good foods and enough of it. You are going to have abnormal stools. For the ascending colon, you're going to have diarrhea. If the cancer is in the descending colon, you're going to have more constipation and some diarrhea. I put in here the flat ribbon-like stools caused by obstruction in red because this is pretty much kind of a sure sign that you've got some sort of intestinal cancer. For a rectal tumor, it's alternating constipation and diarrhea. Other assessments for the intestinal cancer, you're going to have guarding and abdominal distension and an abdominal mass. You're also going to have wasting of the body, and then masses note on barium enema, colonoscopy, and CT scan or sigmoidoscopy. So essentially, they're really looking for it, and if they're going to do CT scan or some of the other scans, they're actually going to see it, but they're really going to do the colonoscopy to be able to go up there and find out if there is. And it's essentially if it's actually inside the colon too. Interventions, you're going to monitor for signs of complications. You're going to monitor for bowel perforation with peritonitis. You're going to monitor for abscesses or fistula formation, which is going to be more of a fever and pain in the abdomen. You're looking for hemorrhaging, blood in the stools, signs of shock, low blood pressure, high heart rate, or you're going to look for a complete intestinal obstruction. The constipation, they haven't gone for days and weeks on end, and they're having more distension, more pain. You're going to monitor for signs of perforation, which is going to be low blood pressure, increased heart rate, distended abdomen, and increased temperature. Monitor for signs of intestinal obstruction, which is vomiting fecal contents, pain, constipation, and abdominal distension. I put in here as far as an NG tube because of the fact that they're vomiting the fecal contents, you really need the NG tube to be able to suck all that stuff out. I mean, I couldn't imagine vomiting my own stool. But anyways, the NG tube is really there to be able to do that and make the patient feel better. For non-surgical interventions, we've got preoperative radiation for local control. We've got postoperative radiation for palliation, and postoperative chemotherapy to control symptoms and the spread of the disease. So essentially, they're either going to use radiation to control the size of the tumor. They can do radiation for making sure that the tumor doesn't get any better, but they didn't really make it any smaller, and it's still there, and it's still actually killing the patient. And they also have chemotherapy to control the symptoms and the spread of the disease. So a lot of times, again, going back to the theory that they're either going to cut it out, they're going to use radiation and chemotherapy to actually get rid of it, or they're really going to use radiation and chemotherapy as a palliative measure to just keep it from getting any bigger and causing other issues, but it's still essentially you're going to die. So other interventions was actually getting a colonoscopy or an ileostomy. Essentially what they're going to do is remove the diseased portion of the bowels and create the pouch. We've talked about when we did the GI area. So for preoperative interventions, consult a stomal therapist. This is really basically, none of us have a six-pack flat stomach, great place to put an ostomy bag, but this ostomal therapist actually can take those who actually have a little extra skin or a little extra weight and decide where the optimal place for the ostomy is going to be. This patient should eat a low-fiber diet 1 to 2 days prior to surgery and administer bowel prep. So essentially, it's just like having a colonoscopy. They're going to clean you all out and make sure there's nothing there because they don't want to see all that stuff. For the colostomy or the ileostomy, they're going to administer intestinal antiseptics and antibiotics to decrease the bacterial content of the colon and to reduce the risk of infection from the surgery. So you have to remember, they're actually going in. You're going to cut through skin, cut through muscle, get to the intestines. They're going to cut out the diseased portion of that and actually either sew it all back together or again form some sort of colostomy or ileostomy based on where that is. And with that comes a lot of germs and a lot of bacteria, and it's not clean. So they're going to do antiseptics and antibiotics to make sure that it stays as clean as possible so you don't get infection from something else. Post-operatively for a colonoscopy, if the pouch system is not in place, apply. All right, so let's see here. Post-operative colostomy. All right, so this is where I want to make sure that I followed some train of thought so you're not lost. So for a colostomy, you're going to have an actual stoma for your feces or for you to defecate through. This slide right here is actually talking more about the stoma itself. So if the colostomy doesn't fit, you're going to apply a petroleum jelly gauze over it to keep it moist, and then you're actually going to cover it with a dry sterile dressing to make sure that it stays as clean as possible. You're going to place the pouch system as soon as possible. You're going to monitor the pouch system for proper fit and signs of leakage, emptying when it's 1/3 full. You're going to monitor the stoma for size, unusual bleeding, color changes, or necrotic tissue. So if it's not nice and beefy red with a little bit of blood, which means that it's very vascular, then something else has gone wrong. Note that the normal stoma color is red or pink, indicating high vascularity. A dark blue, purple, or black stoma indicates compromise in circulation. If it's black, it's dead. If it's dark blue, then it's getting there, and purple means that it's on its way. So just pay attention to that. So here's more pictures post-operatively as far as colostomy and where they're based on where they're cutting the diseased intestines out is where they're going to place it. So it says for functioning of the colostomy, expect the stool to be liquid, but will become more solid depending on the location of the colostomy. I've had patients who have had ileostomies, and literally I gave them a pill and it didn't digest very well, and within about an hour or two later, it's coming out of their ileostomy bag. So, so that's why they say based on where it's placed, it depends on what the stool will actually look like. A ascending colon colostomy will be a liquid, a transverse colon colostomy will be loose or semi-formed, and a descending colon colostomy is going to be close to a normal stool. Let's see here post-operatively. So I mentioned this to you guys in labs before. Here's two people that actually have colostomies, and they've have the bags on, and they actually have nice trim fit bodies, and they do what they can to make it look as pretty as it possibly can. But it's better than dying, and it's better than you do what you can. I had students before mention that they couldn't imagine living with this and what it would be like to have sex and how their life would be. But when you're faced with a situation, it's either death or looking like this, and quite frankly, they look pretty good. So anyway, so for a colostomy, you're going to avoid foods that cause gas or odor, just because of the fact that it is a pouch that is collecting your stool, and it's about 5 feet from your nose. So you're going to instruct the patient on stoma care and irrigation, making sure that everything stays nice and clean and dry and stays as sealed as possible. Instruct the patient on how to resume normal activities. You will eventually go back to work. You still can travel. You can still have sex, and you can still do all the things that you did before. It's just that you're having bowel movements from a different area. It is unusual, it is weird, but in the same sense too, it's just the way it is. So postoperatively for an ileostomy, we've got healthy stoma, which is red, postoperative drainage, and stool is liquid. Again, it's based on where it is. They do have a risk for dehydration and electrolyte imbalance because of the fact that that's where your body actually absorbs nutrients, and wherever it doesn't need, it passes on, and it goes on to large intestines, and they there it will still subtract more if it needed it, but that's most of what your nutrients and your exchange comes in the small intestines. The next one is going to be hepatic cancer. Liver cancer is cancer that begins in the cells of your liver. The liver is a football-sized organ that sits in the upper right portion of your abdomen, beneath your diaphragm and above your stomach. Liver cancer has a low survival rate. Major risk factors include excessive alcohol intake, hepatitis, and diabetes. Symptoms generally do not appear until the cancer is advanced. Treatment options for liver cancer include surgery or liver transplant. Liver cancer is characterized into 4 stages. We've got stage 1, which is the tumor is in the liver and has not spread to another organ or location. Stage 2, either there are several small tumors that all remain in the liver, or one tumor that has reached a blood vessel. Stage 3, there are various large tumors or one tumor that has reached a main blood vessel, and cancer may have also reached the gallbladder. With stage 4, the cancer has metastasized. This means that it has spread to other parts of the body. So for assessment-wise, you're going to have losing weight without trying. You're going to have loss of appetite, upper abdominal pain, nausea and vomiting, general weakness and fatigue, abdominal swelling, and yellow discoloration of your skin and whites of your eyes, which is an indication of jaundice. You're also going to have white chalky stools. For diagnostics, you're going to do blood tests. This will measure the liver function, so you should definitely know what your ALT and AST is. Imaging's first test, you want to do CT or MRI with contrast and advanced imaging procedures such as a MRE. They're also going to do a liver biopsy in some cases to remove a small sample of the liver tissue for laboratory testing. So for the liver biopsy, a needle is inserted through the abdominal wall to the liver to obtain a tissue sample for biopsy. For pre-procedure, you're going to assess coagulation tests such as PT and APTT. This is because of the fact that obviously if your liver is damaged and this is where your coagulation happens and it's not doing well, you can't necessarily do biopsies or incisions because you don't have the clotting factor. So you want to make sure that you actually look at those 2 tests. You're also going to administer a sedative, so that way the patient can kind of not be aware of the fact that you're cutting into them and puncturing their liver. Place patient on the left lateral position to expose the right side. For post-procedure, you're going to assess vital signs, assess biopsy site. You're going to monitor for peritonitis. You're also you're going to be in bed rest for several hours. You're going to place the patient on their right side with a pillow up against them to decrease the risk of hemorrhage. So essentially you're using it as more of a splint, and then no heavy lifting, obviously. So for treatment, you've got the partial hepatectomy when the tumor is small and occupies a small part of the liver. That part of the liver can be surgically removed. Many people with liver cancer have cirrhosis. This means that the hepatectomy needs to leave behind enough healthy tissue for the liver to perform its necessary function after the procedure. They also could do a liver transplant. Candidates for a liver transplant cannot have a tumor larger than 5 centimeters or several tumors larger than 3 centimeters, and the risk of cancer returning is too great to justify a procedure as risky as a transplant if the tumor is larger than this. So essentially they're going to weigh the pros and cons. I mean, if you're an alcoholic and you're not planning on stopping drinking anytime soon, then they're not going to give you a good liver. same thing with this. You can get a new liver, but if it's metastasized to other areas, or if the tumors keep growing back, they're not going to give you a nice healthy ones for it to fail also. With a successful transplant, the risk of cancer returning is greatly reduced and the normal function can actually be restored. So you want to start off with, with being able to remove it, give you something nice and clean, and that way you can live the rest of your life, cancer-free. However, the immune system can reject the new organ, attacking it as a foreign body, and there are limited opportunities to carry out transplants. Only around 6,500 livers are available each year, and many are used to treat diseases other than liver cancer. The drugs that suppress the immune system to accommodate a new liver can also lead to serious infections and on occasion even the spreading of already metastasizing tumors. So if you do get a good liver and everything seems to be really well, you do have to be on anti-rejection medication for the rest of your life, and that actually could bring other serious illnesses and diseases. Interventions, you're going to look at liver labs. You're going to look at giving pain medication for the pain. You're also going to give nausea medication for the nausea. For the liver transplant, you've got cardiac pulmonary problems. You've got anti-rejection medication and corticosteroids, and the prevention of viral, bacterial, and fungal infections. So, it's great that you got this new liver and that you can live a long, healthy life, but unfortunately you don't get to leave the house because you're too much of a risk of actually catching something and then causing you to get sick, and then eventually you die anyways. The next one is pancreatic cancer. Most pancreatic tumors are highly malignant, rapid growing, originating from the epithelium of the ductal system. Pancreatic cancer associated with increased age, history of diabetes mellitus, ETOH and smoking, history of pancreatitis. So the more often your patient has pancreatitis, the more chance of them actually getting cancer. And then also the ingestion of high-fat diet. Symptoms don't usually occur until the tumor is large and prognosis is poor. I believe there's 4 stages, and usually it's around that latter part of the 3rd stage and the beginning of the 4th stage that the symptoms show up, and that's what causes people to come to the hospital to determine why they're not feeling well, and that's when they find out they have pancreatic cancer. Let's see here, things that they can do as far as testing. They can do ERCP for visualization of the pancreatic duct and pillary system. The collection of tissue and secretions may be done. For an assessment, you're going to look at nausea and vomiting. You're looking at jaundice, unexplained weight loss, clay-colored stools, glucose intolerance, and abdominal pain. And for interventions, they can actually do what they call a Whipple, which means that they actually remove a portion of the pancreas and connect it to the actual intestines. So interventions are radiation, chemotherapy with the Whipple procedure. I put down here pre-op and OR and PACU because I want you to actually keep that mindset of, okay, so they're going to go and have a surgical procedure, whether they're removing the pancreas or do a complete Whipple. But I want you to think of, pre-op, their MPO, make sure the consent forms are signed, making sure that all the labs are done. They're going to the OR. Can they actually, withstand the anesthetic? Are they able to take and, be able to do the surgery and actually live through it? And then PACU, you're looking at vital signs, making sure that they're not going to bleed, making sure that their pain is controlled, making sure that their nausea is controlled. So keep in mind when you think of procedures, medical procedures, surgical procedures, that you're thinking in a wider range as far as pre-op, OR, and PACU, not just, oh, we're going to have this done, because there's so much more to it than that. And then next up, we are on renal cancer. Kidney cancer. Rarely it causes signs or symptoms in its early stages. Currently, there are no routine tests used to screen for kidney cancer in the absence of symptoms. Factors that can increase the risk of kidney cancer include older age, smoking, obesity, high blood pressure, treatment of kidney failure, family history of kidney failure, and exposure to certain substances in the workplace, such as herbicides. Assessment-wise, you're looking at blood in your urine, which may appear pink, red, or cola-colored, pain in your back or side that doesn't go away, loss of appetite, unexplained weight loss, tiredness, and fever, which usually comes and goes intermittently. Medical management is going to be a nephrectomy. The positive thing is you have 2 kidneys, and if you have cancer in one, then you can actually have it removed and still have, another functioning kidney. Other medical management is going to be renal arterial embolization. They can do pharmacological therapy. They are not eligible for a kidney transplant if they have kidney cancer because they'll come back. Nursing management is going to be pain medication, education, and transitional care. Last one is going to be testicular cancer. It's rare cancer affecting men, usually between 20 to 35 years of age, usually curable with early detection by testicular self-examination. So for all those guys that are doing their own exams, then they're able to, and a lot of times they actually find that it's the partner, the sexual partner of the man that actually finds it, because guys tend to not necessarily look for things particularly, and if they do find stuff, they don't usually think about it or don't tell anybody. So it's the partner that usually does. You've got germ cell versus non-germ cell tumors. Risk factors are undescended testes, family history, or of testicular cancer. The most common manifestation is painless, hard swelling, enlargement of a testicle. Psychosocial assessment, so focus on sexuality. What that means is that for men, we're sexually driven, so you start removing things and we start freaking out about whether or not things will still function after things have been removed. Yes, you can still have sex, you can still produce children. If they leave one but remove the other, then you still can actually have children, and you have enough hormones to be able to have that work. I think that's it for so far. So here is a picture of testicular cancer. The testicles on the far right picture. The left side is the normal one, and then testicular lumps are on the right side. Diagnostics, they're going to do laboratory assessment. They'll run an alpha fetoprotein test. They'll also do beta human chorionic gonadotropin. They're also going to look at lactate dehydrogenase, or LDH. Other diagnostic assessments is going to be ultrasound, a lymphangiography, and an MRI. I have actually had friends who have had an ultrasound done on this, and it was quite painless, and they had some swelling. That's what made it go, but of course they waited until it was like, baseball size. And then, according to the doctor, they give it some time, and sometimes your lymphatic tissue becomes swollen and for no reason, and then eventually went away. But just the idea of waiting for that to go down and not worry, it's kind of hard. So more about testicular cancer. Surgical management, we actually can do an orchiectomy, which is removal of the testes. They can do chemotherapy. They also can freeze your sperm for future children. So for those men who actually have testicular cancer of both, they can actually freeze the sperm and then remove them, and then in the future you can actually unfreeze it and still have children. All right, so chemo patient. Again, these are more interventions for that patient who's on chemotherapy. So we've got analgesics for pain. We've talked about morphine, Dilaudid, and fentanyl before. Morphine is probably going to be roughly 4 milligrams IV. Dilaudid is probably going to be 1 or 2. And fentanyl is measured in micrograms, so they're probably looking at 50 mics. We've got Percocet, Oxy-IR, we've got Oxycontin, and Percodan for orals. Usually you're going to take 2 pills once every 4 hours. There are some that, like the Oxycontin, that's actually every 12 hours. The Oxycontin you can do every 12 hours for a long-lasting pain management, and you also could do Oxy-IR with it and then do that every 4 to 6 hours just to make sure that things are as pain-free as possible. We've got the antiemetics, which is we got Benadryl, which we commonly know to use it as something for itching, but it also can actually take away some of the nausea. We've got Zofran for nausea. We've got Phenergan, which we mentioned before. Phenergan actually has a sedation side effect to it, so watch your patients you give it to, so that way they're not completely loopy and you don't know why. It's probably because of the Phenergan. And we've also Compazine. Usually in the hospital, they'll try Compazine first, Zofran, and then Phenergan. We've also got anti-neoplastics. Anti-neoplastic medication kills or inhibits the reproduction of neoplastic cells, used to cure, increase survival time, or decrease life-threatening complications. Not limited to neoplastic cells, also affects normal cells. So, when you give your patients chemo, it is literally killing off everything. I mean, every cell. The patients are so sick because you're literally giving them poison to kill off, all the best cells of the cancer, but it's also killing off the good stuff too. Several medications are often used together to increase therapeutic response. Administration through PIC or implanted port. So this cannot go through any sort of IV. It can go through an A line. It can't go through anything except for a PIC or implanted port. Titrated based on body surface area, so they're looking at height and weight and the type of cancer. So there's a whole sheet that they do all these calculations on to make sure that you're getting the right amount of medication for your height and weight and everything else. So it's pretty intense, but in the same sense too, they want to make sure you have enough for it to work, but not too much to actually do what it's not supposed to, which is kill you. Side effects of these anti-neoplastics are mucositis. We've got alopecia, which is hair loss. We've got anorexia, nausea, and vomiting. So again, try to stick with the frequent meals throughout the day. You're also going to have diarrhea. So again, look at the labs: potassium, sodium, magnesium, phosphorus. You're also going to have a low white blood cell count, which is also called neutropenia. This is because, again, the cancer is literally, or the cancer medication, the chemotherapy is literally killing off everything. So without the white blood cell count being high enough, that you have a better chance of getting other diseases such as pneumonia, C. diff, MRSA. I mean, anything you come in contact will make you sick. It will also cause infertility. General interventions. You're going to monitor CBC, WBC, platelet count, uric acid level, and electrolytes. Initiate bleeding precautions if thrombocytopenia occurs. When platelet count is less than 50,000, minor trauma can lead to prolonged bleeding. When platelet count is less than 20,000, spontaneous or uncontrollable bleeding can occur. Monitor for petechiae, ecchymosis, bleeding of the gums, and nosebleeds. Avoid intramuscular injections and venipuncture. So obviously you're going to stay away from Levinox shots and heparin shots. Initiate neutropenic precautions if white blood cell count is low. Monitor for fever, sore throat, unusual bleeding, or signs of infection. Inform patient about loss of appetite and taste changes, such as bitter and sweet. I have in-laws that both died of cancer. One had lung cancer, one had pancreatic cancer. And with the chemotherapy, they either everything was just really, really super salty, or everything was just super, super sweet. And they felt like they wanted something sweet, and then they got it, and they just didn't like it, and they wanted something salty. So it just really screws up your taste buds. For nausea and vomiting, we use antiemetics to keep on schedule. So, there's nothing wrong with giving your patients, Zofran every 6 hours just to keep the nausea away. I know it's PRN, but a lot of times we forget that, we didn't really ask, so we didn't really give it. And it's like, well, how about we just keep giving it to make sure that you feel better? You're going to try to promote high-calorie diet with protein supplements, and you're going to encourage hydration, IV fluids, or try to drink at least 2,000 cc's a day, which is kind of hard for somebody who's nauseous and vomiting. But if you stick with some sort of antiemetic, that actually works, and then you can actually try to get as much food and fluids in them as you possibly can. You want to also worry about, say, handling, wear gloves and gown, eye protectors, and masks when handling IV medication. Anti-neoplastics, I mean, if it's going to, cure their cancer and actually kill off everything that's inside them, it's probably going to do the same thing to you. So you want to make sure that you don't touch it. Make sure everything stays inside the tubing, inside the bag, and you're not really coming in contact with it. And you are going to actually wear gloves and gowns and eye protection because, again, you don't need that, if some things happen and you just don't need to wear it. Obviously, you're not going to administer if you are pregnant, and you're going to monitor the PIC and port for signs of infection and patency. So again, this is their lifeline. So you need to make sure that everything works from the PIC to the line to the chemo itself. I mean, you're making sure everything actually works, because if the PIC doesn't work, then you need to change it, and it needs to be changed in a timely manner because they need to get their chemo every single day or every other day or however their regimen is. If there is some sort of sign of infection, it's actually going to probably be the PIC or the port, and it's because of the fact that, We just don't do a good enough job as far as keeping it clean and sterile and keeping it covered and doing the best we can to actually make sure there's no sign of infection or signs or infection doesn't get into it. So we need to do a better job of that. Just be conscious of it. Health promotion and maintenance. If patients having diarrhea, avoid spicy foods and high fiber foods. Good oral hygiene. Use rinses after every meal. I wouldn't necessarily use Listerine, but I know that you can use chlorhexidine mouthwash, which will actually keep things nice and clean. Use antifungal agents such as nystatin, which is that swish and spit stuff. If there are fungal infections, it's because of thrush. So I've been told that nystatin, a swish and spit, is pretty nasty, but if it keeps the thrush away, then that's better than nothing. You're going to avoid crowds and people with infections because, again, you don't want to get sick yourself. Use a soft toothbrush and electric razor because of the possibility of thrombocytopenia. Obviously, no aspirin to make your blood thinner, and no live vaccines because, obviously, that's going to not work for you with no immune system. Let's see here. Patients also have the possibility of having anaphylactic reaction. You're going to do precautions, which is obtain a allergy history, administer a test dose. So sometimes you'll give like a really super small dose just to see how they react to it. You're going to stay with the patient, make sure that they're able to breathe, make sure they don't have any severe reaction. You're going to monitor vital signs, have cart close, and then make sure that they're picking their port works. There's nothing worse than having a patient code and then having 2 or 3 IV access sites and none of them work. Signs of anaphylactic reaction are shortness of breath, chest tightness or pain, pruritus or urticaria, tachycardia, dizziness, anxiety or agitation, flushed appearance, hypotension and decreased sensorium, and cyanosis. Essentially, they stop breathing, the heart stops, and everything just stops. Nursing actions is going to assess breathing, stop medication, vitals, administer Benadryl, sit patient at high hours, elevate the feet, do not remove the IV or pick or port, and document the event. Well, it wasn't too bad. Got done in 36 minutes. So if you have any questions, I know I ran through things very quickly, but we're going to go over most of the stuff in class. So definitely bring your questions. Make sure you do all your reading, and we'll go from there.